Hello, a very good afternoon to all of you. I'm Dr. Victor from Island Hospital. I'm an ENT surgeon. As you can see, I'm all masked up, and I just want to tell you this is how we embrace our new normal in this pandemic time. So this is what we have to wear. I have to wear goggles. I have to, of course, beneath my glasses, and then this is my mask. So I'm going to take out so that at least we can uh, have a small little sharing here. Okay. So as I think many of you are not aware, this week is actually ENT Kids Health Month. Okay, it's awareness for the ENT community and for people to know that there's actually such thing as ENT Kids Health. So I'm invited to share with you the common ENT disorders or conditions that we see in children. All right, so I think before I start, I think I have to commend our multimedia team here. They have been dedicating themselves to bring, I think, a series of lectures and a presentation on Wednesday afternoon. All right, this is my second time chipping in. So let me get right to it. So common ENT disorder in children. Okay, so I'm Victor from Island Hospital. I've been here for I think about time flies as you know. I think about 10 years now. Yeah. So this is our view of our hospital, an aerial view of the hospital. Okay, you can see over there. All right. So I'm gonna cram a lot of slides with pictures. Okay, so I won't want to bore you. I think, as you know, as the saying goes, picture paints 1,000 words. So we start with E, okay? E stands for ear, so ear disorders. These are common ear disorders. In children and in adults, okay? I just want to highlight here that in my practice, I see roughly, I think I'm delighted to see quite a lot of children in my practice, roughly about 30% of my practice dedicated to children. And you can just let me assure you that it's a lot more rewarding to treat children uh, and all their little antics to see them and to be able to help out in this ENT problems that they have. So let's start with common ENT disorders, okay, ear disorders. All right, so I just want to highlight here the anatomy of the ear. I'm going to use my pointer here. So okay, so this is the outer part of the ear, okay, and then you have a canal all the way into the eardrum here, and then you have the what we call the inner ear, okay, and you can see here there's a tube. It's called the eustachian tube that connects to the nose. All right. Okay, so this is how we define the outer ear. Outer ear actually all the way from here all the way to the eardrum, and then this is the middle ear, and then this is the inner ear. All right, divide into three parts. Okay, all right. So you can see one very common, all right, very common problem that we see on the outer ear. Okay, this is the parts of the outer ear. All right, and I don't know whether you notice some of our children, we have this problem, a small little dot here. All right, okay, it's actually what we call a preauricular sinus. So right here, and this small little minuscule dot here can cause mighty big problems. Okay, they can come with a lot of crusting, and then they can cause all these problems here, and then these are more advanced problems. Okay, and they can come on with a lot of discharges and all that. So fairly common preauricular sinus, the outer part of the ear, and then trauma, very important. Okay, so of course this day and age we don't advocate strict disciplinary action by teachers slapping the children. Okay, they cause very bad trauma, and they can cause problems with the ear, the outer ear, and also perforated eardrums. Okay, we see this on and off, actually pretty common. Okay, what do you think happens here? This is what we call keloid, right? So keloid over the outer part of the ear. Okay, this is called the earlobe. All right, so this is a keloid. So fairly common, the outer part of the ear. All right, so another problem, what we call perichondritis, inflammation, all right, infection of the outer part of the ear. And you know what causes this? Most of the time, it's not any bacteria, it's not any insect, okay, that happens too, but more commonly due to, all right, the wrong usage of certain ear drops. All right, over-the-counter ear drops can cause massive reaction to the outer ear, and they can cause perichondritis, the outer ear. And then if you leave it long enough, we call it a cauliflower ear. So it looks like this. Okay. Okay, so I'm gonna now zoom in into the middle, this part of the ear, which is the ear canal, which is still the outer part of the ear. Okay. Okay, almost every day I would say. All right, we will definitely have one or two cases. This is the eardrum. You can see minimal earwax, but you can see what we call impacted earwax. Okay, so the common presentation, it will be a child, okay, coming in. The mother will say, "Oh, I can't seem to hear me, can't seem to obey commands." Okay, so they will have a look inside the ear, and then they see all this blackish thing inside. That's one presentation. And then not too uncommon, unfortunately, is mother will be coming in and say, "Oh, just had bleeding from the ear." So what do? Very commonly, they will try to dig the ear wax out by themselves, and many a times it will cause a lot of trauma. All right, as you can see, it's all deep inside. The more you use the cotton bud, it will actually push the ear wax deep inside. All right, so we obviously do not recommend self DIY at home, with the earwax. Okay, and then if the earwax get a bit too embedded far too long, they can cause something called otomycosis. They're actually fungal infection. All right, fungal infection. It also happens in a lot in adults, but it also happens in children. And then there's a very peculiar problem. It's called keratosis obturans. It's not really earwax, but it's similar to earwax. What happens is that this canal, it looks something like earwax. What happens is that the canal will form this keratosis layers. It's like onion peel, we call it, layers of skin. All right, that will be eroding the canal, and a lot of times, even during this MCO, almost I think once I've been doing like at least 4 or 5 for the last 1-2 months. Patients with this keratosis obturans, okay, extremely painful. Patient will come in extremely painful, and then with a chronic history of blockage for quite a while. Yeah, so you look up this something called keratosis obturans. Okay, so that's the outer part. Foreign body, very common too. Okay, so a no-no will be what we call batteries. This is a acute emergency. All right, when you have batteries in the ears, okay, they tend to leak. And then you can cause erosion of the ear canal. All right, cotton bud also very common. A lot of beads, rubber fragments, and then beads, Lego, small little Lego sets is also pretty common. And organic versus inorganic. Okay, so you have small little seeds and then insects. All right, okay, as you can see, this is I actually have patient with a cockroach inside. Okay, a live cockroach. One day I remember very early in the morning, 8 plus in the 7 plus or 8 plus in the morning. This person comes and says, "Hey, doctor, I think there's a cockroach." I couldn't believe it. Even that was quite a few years ago. All right, so it was actually a live cockroach. All right, so I'm afraid of cockroaches, I have to say, but somehow I still have to put on a green face and then pull it out. Okay. All right, so that's the ear canal. So I'm still with the ear canal now. So we're going to talk something maybe many of you parents will know about. Okay. The medical term here is otitis media. All right. So we are talking about the middle ear here. All right. We're talking about the eardrum here. This is called the middle ear. Okay. So what happens is that you have the eardrum. It looks like this. This is the left eardrum. And then you have the eardrum. You can see different types of discoloration, correct? So you have actually fluid behind the eardrum. All right. Media means the middle part of the ear. Okay. So you can see a different spectrum of presentation. All right. We talk about the acute otitis media. So how do children present? Okay. So many a times they come in with a preceding URTI, that means cough and cold, our usual cough and cold for a week or 5 days, and then cough and cold usually start to resolve, and then they start presenting with ear pain, acute ear pain. All right, that's the what we call acute otitis media. All right, so but I just want to highlight here, all right, that sometimes it doesn't happen with URTI. It happens with the way we feed our small little babies and then our kids. All right. So regurgitation of milk, vomiters, it actually goes up and then it can go through the eustachian tube. I'll just go back again. Remember this tube that I mentioned earlier? Okay. So this is what we call the eustachian tube. Okay, imagine this is the back of the nose. All right. So milk can actually go in here. All right. So what happens is that in a child, as you know, the ENT region, they're still developing. Structurally, immunologically, it's still infantile. So as they grow, this tube, when at birth, it will be almost horizontal, okay, to the nose. So anything that goes to the back of our mouth and the nose, it will actually have a tendency to go in. That's why it occurs a lot more frequent in children, okay. As we grow, okay, it will tend to grow downwards and the angulation will be more steep, and of course gravity helps us to prevent any recurrence or reflux of fluid into the middle ear space. Okay, so let's go back to otitis media here. So you can see the eardrum comes in different forms here. All right, okay, so we were here, and let me continue here. Usually a lot of pain, crying away. Sometimes I've seen children banging their head against the wall, okay, and then after that, if you don't bring them early, what happens is that they will later develop discharge, and usually the pain will go away. And what does that signify? It's actually not a good thing, because what happens is that there will be a perforation. It's like a balloon under tension, and then it will burst. Once it bursts, then the pressure goes off, the pain will go away. But the discharge can be quite florid, can be quite purulent, and then that's what happens when you see in the adult population. They often come in with eardrum perforation, when the eardrum has a hole in it and it has been discharging intermittently over years. All right, so you want to catch it very early in a child. All right, so what happens is that see a very acute pain, all right, you actually try to get to see one of us. Yeah. Okay, so in a chronic form, so lucky or unluckily, some children may not exhibit any pain, and then this fluid will not get too infected or acutely, and then they become just what we call glue ear. So you can see here, another term is middle ear effusion. All right, so you can see here is usually this, it has an orange hue. Okay, and this is a normal eardrum. So normal eardrum, you can actually see that it's transparent, and you can see parts of the ossicle, which is the bone of the eardrum, of the ears, okay, over here, and then you have a cone of light. So this is normal, this is abnormal. Okay, all right, so let's move on. Yeah, so we will of course try medication first, and assuming medication does not work, 50% of the time it does not work. Okay, then you have to put what we call a grommet. Okay, a grommet is a French word, a ventilation tube. Okay, all right. Okay, before that, we also have to make sure that the hearing is good and all that. We do what we call an audiogram. We do something called a tympanogram. Okay, I'll be one experience that I can tell you is that many a times when I put the tube, I'll show the parents this. Okay, what happens is, in due time, when the eardrum recovers, the tube will automatically extrude out, and then there will be a spontaneous healing. And I can tell you almost every single time when I follow up with a child and it actually comes out, okay, over here is actually very, very small. So it's a microscopic surgery, very extremely small. And then patients and the parents will be, how do you manage to put this small little thing inside the eardrum? Okay, all right. Okay, so middle ear, we're still at the topic of middle ear. As I mentioned earlier, if you have acute problem and you don't seek treatment, or you do not know it's an acute problem, the eardrum can actually perforate. When it perforates, I have my colleague here trying to disturb me, Dr. Gore. So anyway, chronic otitis media, so what we call perforation of the eardrum. This is not a good thing, because what happens is that it will be chronically discharging. And then you have something even worse. They can develop cholesteatoma. Not very common in children, but as you can see, we deal with all sorts of ear problems. So unfortunately, it's not a good problem to have. So you can look up cholesteatoma. Very commonly, we have, of course, children with parents bring them with hearing, different level or different spectrum of hearing loss. And many a times they don't, parents may not know that they have very severe hearing loss. They may just have very mild hearing loss. What happens is that the deterioration in school performance is extremely vital in the history taking. Often we have parents tell us, oh, the last standard 1, standard 2, they're doing so well, always first in class, and then somehow, for some reason, standard 3 start to deteriorate, and then, can't seem to catch up. So you realize that many a times there's a component of hearing loss. I just want to highlight here that we have congenital hearing loss and acquired hearing loss. We have something called conductive and sensory neural. These are just medical terms here. Just want to let you know what we call. In children, what we see is most of the time is has to do with middle ear effusion, and then earwax problem, especially impacted earwax. Medication, of course, if you talk about children who unfortunately may have other diseases that may require long-term medication, cancer treatment, things like that, it may also cause hearing loss. And then sensory neural usually has to do with antenatal. They may be born with just deafness, and it's a nerve problem. So we have to bear in mind, and as an ENT doctor, we have to come to a diagnosis. We have to come to the cause of the diagnosis, and then we can treat. So these are certain parts of what we do. So as you know, I want to just show you here different developmental milestones. At 2 or 3 months, okay, they will startle the reflex. 5, 6 months, when the eyes and the head get stronger, they can tend to roll their rolling eyes, they can move their eyes, and then the head turning at 6 months. So things like this we have to observe. And then speech development. And anytime when there's a delay in the developmental of the speech, okay, you have to have a very high index of suspicion. And these are certain things you do. You may know some parents. It's quite universal now to do what we call a OAE. This is universal neonatal screening. To see, we can screen a child whether there is any possibility of a hearing problem. I think here in Ireland is quite universal here. It's offered to all newborns. As the child grows older, you can do what we call a pure tone audiometry. Usually about 5 years and above. Yeah. And then when we talk about sensory neural deafness, we do something called okay, what is this? This is a hearing aid. And then I just want to introduce you to you what we call a cochlear implant. I'm sure you've heard of this. Okay. So we do here. We also do a cochlear implant in our center. So how to differentiate? I just want to show you this. Okay. So pictures that, as you can see, pictures that I don't have any blank out of the face is not is in a public forum. So you can see this processor, okay, external part, okay, and also this part here. The processor has 2 parts. So this is a cochlear implant versus this one over here. This is just a hearing aid, and it's a fairly old hearing aid. Nowadays you have very nice, beautiful hearing aids here. So you have what we call the sound processor here, okay, and then it has the implant that is inside. So we usually embed it on the skull, and then you have what we call electrodes that go into the cochlea. So we are not talking about the inner part of the ear. Okay, so I'm gonna now go into the next part of my presentation, which is on the nose. So what are the common problems that we see? So I just want to tell you, foreign body again very common, and epistaxis. This is the medical term for bleeding in the nose, yeah, nasal bleeding, and then rhinosinusitis getting more common in the pediatric population nowadays, and this is a huge chunk of our problem, allergy. Okay. All right. So if you can see a side profile of the nose, okay. So this is the outer part of the nose, and you can see this what we call turbinates. We have 1, 2, and 3 turbinates, and then that is the back part of the nose, and then this is the mouth area, yeah, and the palate. This is some orientation for you. Okay, so very common. Again, you have organic or inorganic. Batteries again is an acute emergency. So we always say ENT. ENT actually stands for ear, nose, and throat. So in our faculty, sometimes we say every night tidur. Okay. So what does it mean? That means there are not many emergencies. We don't really have to come to the casualty that often, but our emergencies can be very, very bad. And one of the emergency is what we call battery lodged in the ear, in the nose, and also the ear. Okay, so it can lead to a very fast deterioration. The chemical can leak, and then it can cause perforation and cause a lot of problems. So one of the emergency that we deal with is batteries in the ear or in the nose. So common peanut, no, maggots not common. Okay, peanuts also fairly common. Toys, different parts of the toys also very common. Okay, usually we don't need do any X-rays, but sometimes if we can't see and then the child is not very cooperative, we may subject to some simple X-rays. Okay, you can see here. Okay, this is the battery. Okay, so epistaxis is also very, very common. Almost every other day, I think we will have one child coming. Again, the spectrum from very mild to very severe. I just want to highlight here that many a times it's a local problem. That means it has to do with just a simple problem of the vessel. There's a Little's area. You can Google up Little's area, the front part of the septum that is highly vascular, and in a child, the layering or the mucosal layer is still fairly thin, so it tends to bleed many a times due to, especially boys. That's my inclination. No speaking. All right. So and sometimes have to do with allergy rhinitis. They can't help it. They keep on rubbing their nose and picking the nose. So trauma, inflammation, sinusitis. And all right, I want to also highlight here, if you have a child, always have this high index of suspicion. If for some reason keep on bleeding and then you recurrent bleeding, and you do not you probably have a look into the nose in a cooperative child, and you don't see any vessels. All right, so just make sure that you rule out any hematological disorder. So we just have another, we diagnosed a case just about a month ago, a child with some bleeding from the nose, and then thought to be just benign, and then turn out that you do the full blood count, there's thrombocytopenia, okay, platelet disorders, then it cause to all these problems. So at the back of our mind, always remember that if you have exhausted all your scopes and then you don't find any clear-cut cause of the bleeding, just do a full blood count, coagulation profile to look at any problem with the bleeding disorder, a systemic problem. Okay, and I just have to tell you this, not common. Okay, this is really not common, fortunately. Something called JNA, juvenile nasopharyngeal angiofibroma. It's a benign tumor, but it can bleed torrential bleeding, okay, torrentially. Huh? So not common, usually occurs in male, male predisposition, huh? And they usually about above 6 years old to the early teens, they can cause this problem. Okay, so this is how we do a scope. I think I have to tell you, through my experience with children, I have to salute them because many of the times they are very cooperative. They're much more cooperative than we let them to think. Because many of the times I would say on average 5 years old they allow you to go into their nose, okay, open their mouth. Of course, you have to be very gentle, and then make them comfortable. And I don't think I would say 80% of the time above 5-6 years old they're okay. They'll allow you to go in. But of course, you have that 20-30% where they will absolutely, as soon as they walk in the door, they'll be screaming. But we'll do what we can. All right. In the most severe of cases, you also have to do some nasal packing. Not common, but you may have to subject the child to all this. So we spoke about bleeding, very common, foreign body of the nose. Yes. So I'm going to talk to you about allergy now. So the big part of my practice, especially in the pediatric population. So allergy, basically, I tell patients that how do you get allergy? Okay, as an allergic reaction, basically any substance. You can be inhaling, okay, inhalation. You can be taking ingestion. You can be injecting. All right, like for example, a bee sting, or any drugs, skin contact, okay, that can cause allergic reaction. So I deal a lot with the runny nose in a child. So they come in all shapes and sizes and form. So I want to highlight here what we call allergic rhinitis. I think probably in my early days, people will always say, come in, as soon as they walk into the door, oh, my child has sinusitis. Okay, or the GP says my child has sinusitis. So I can tell you many a times they do not have sinusitis. They have rhinitis. I'm going to just explain to you what it means. All right. So we define allergic rhinitis as a major chronic respiratory disorder. Okay. All right. So this is one word here that you hopefully is a paradigm shift. It's actually a respiratory disorder, or what we call like a lung problem. Okay. I'll tell you why in a short while. And then you have to make a diagnosis, different sort of treatment for different type of allergies. And then more importantly, it has what we call associated complications. Some patients will have different other complications. And therefore, when you diagnose, you decide on the modality of treatment, and then you decide on the severity of the problem, and then you can treat. And then obviously different ways to skin a cat. So you combine different treatment strategy. All right. Okay, I'm just going to illustrate here. So this is a big circle called allergic rhinitis. So you can see other problems. You may be familiar with a few words here. Allergic rhinitis, the association with asthma, association with sinusitis, and then we spoke about otitis media earlier. All right. Eye problem, conjunctivitis, red eye, skin problem. All right, and very important here, okay, the relationship between allergic rhinitis and asthma. Okay, I think I'll dwell a bit on this important aspect of allergy. So as I mentioned, we look at the patient, we examine the patient, we do a scope as much as we can do allergic testing, all right, things like that. All right. Okay, so what happened is oh, so do I answer now? You want me to answer now? Oh, okay. Apparently, there's a question here. Okay. So I'll try to answer right now, a short answer, and we can elaborate further. What 7-year-old child, is it common to have sudden episodic relapse? Yes, definitely. Okay. All right, okay, let me continue with this first. Okay, I just want some DIY at home for you guys. So now in the era of COVID, uh, I'm sure you know that you're aware that anosmia means they cannot smell. Okay, it's one of the early signs of a patient with COVID. So we have been having quite a few patients, especially adults who come in, just want to check the nose to see whether they have COVID, things like that. So I want to just let you know, you developed this easy itchy A B C D E. Okay, this is how you diagnose allergic rhinitis. You diagnose your own child. Oh, can I show this? So what does A stand for? Okay, so basically, how do you sneeze? You sneeze with the chew. Okay, so that's A. All right. B stands for blockage of the nose. C stands for cough, and usually very irritating, dry cough. Discharge from the nose, watery discharge. Post-nasal drip. Adults will usually tell you that, not in a child. And eye symptoms. So itchy nose and ears. Then the expression of achoo, A. B, a lot of blockage. At night usually or early morning. Cough. And then discharge of the nose, D. And E, eye symptoms, itchy eyes, red eyes. So this is how you diagnose allergic rhinitis. Itchy A, B, C, D, E. Okay? So this is as easy as ABC, right? Okay, so sometimes from afar, as a child comes in through the door, more or less you can tell, oh, okay, does your child have allergy? I will sometimes ask, because I can say this. This is the classic allergic salute, because the child keeps on doing this, okay, and they develop a permanent crease, yeah, over the mid part, the dorsum of the nose over here, and this is called allergic, so-called eye bags, okay, allergic, Dennis Morgan lines, we call this, okay, all right. So then you can use small little instrument here, but nowadays we use a scope. Okay, so as you know, as I tell you, allergic rhinitis impact not just the child but also the parents. And then the child can also exhibit problems that affect their school performance, irritability, psychological problems. So nasal congestion can develop and also disturb abnormal sleeping patterns. Okay, so they don't do well in school, they get daytime fatigue, irritability, and then of course when they don't do well, then they get mood disturbance, and then it become a vicious cycle. All right, so okay, so remember I show you this picture. Maybe I'll just show you. This is what we call the turbinate. So we are going in over here all the way to the back. Okay, all right. Okay, so for you adults over here, okay, like I say, in a child, all right, in an adult, you always want to have a look at this part of the nose. It's called the nasopharynx. Very commonly, we have an unfortunate problem called a nasopharyngeal cancer, PI. Okay, so it's nose cancer over this part. Very common. Okay, my last diagnosis was just a few days ago, unfortunately, in a man. So I just want to highlight here that this is a normal view of the nose, okay? And then you have to look at this part here. The upper part is called the middle turbinate, and they must be clear, okay? All right. Remember, I was telling you that allergic rhinitis can lead to other problems, yeah? So we're going to start with sinusitis. Obviously, if you have a lot of allergy going on, inflammation going on in your nose, so this is the nose. If you have problem just confined to the nose, we use the word rhinitis. Okay, rhino. Okay, rhinitis means nose. So this part. But obviously, if it gets more severe, it will lead to problems, inflammation into the sinuses. This is called the maxillary sinus. All right. So this is the maxillary sinus. This is the frontal sinus. You have many ethmoid sinuses over here. Okay, and something called sphenoid sinus. All right. So sinusitis, the medical term is actually rhinosinusitis because there's a rhine the nasal part and also the sinus part, okay, rhinosinusitis. So it's very important to tell you that you have rhinitis and you have rhinosinusitis. And you have 1 year old coming in and say, doc, somebody says, or my GB says my child has sinusitis. Many a times you cannot have sinusitis. Why? Because your sinuses are still developing. Huh? So you have very small maxillary sinus when you're born, ethmoid very rudimentary, and then your frontal sinus especially, they don't develop at 1 or 2 years old. They fully develop much later on in life. So how can you have sinusitis? You probably just have rhinitis. Okay? Very bad rhinitis going on. Than a full-blown sinusitis. But unfortunately, I would say, I started doing ENT probably 20 years, odd years ago. We don't see many rhinosinusitis in a child. But I have to say the last 8-9 years, you get more and more common. It gets more and more common, unfortunately. The presentation of rhinosinusitis in a child. Okay? I just want to caution you here that do not take rhinosinusitis lightly in a child because they can develop orbital complication. Not common, but it happens. Okay. This year I haven't seen one yet. Last year I seen one, but I did not have to go in for an operation. The year before I had to go in for an operation for a very young girl. So orbital means eye, and then you can have cranial, intracranial complications. So this is one outpatient long time ago. Okay, you see? I'm sorry to show you this just to let you be aware that you can have sinus problem resulting in eye complication. And then you have what we call frontal lobe over here. Okay, this is a abscess in the frontal lobe. Patient usually present not to us. They present to the neurosurgeon. They come with fainting spells. They can get into seizures, fever, and then they check. Usually present to the neurosurgeon or the neurologist, and then they do a scan. And abscesses. Then they find out also has problem with the sinus. All right, so that was sinusitis. Again, I just want to tell you, a lot of times they go hand in hand, allergic rhinitis with otitis media, the effusion that we mentioned earlier, glue ear. Okay, so again, some of the photos here. Okay, this is a acute form. All right, and then of course, if you don't take care, they have chronic otitis media. They have a permanent perforation that can be quite troublesome. Okay, so polyp, peeling, okay, in Hokkien, see this very frequently in adults. I also want to tell you that again, similar to rhinosinusitis, we also unfortunately seeing an increased incidence of nasal polyposis the last 10 years or so in a pediatric population. Okay, so this is the turbinate I mentioned. Okay, this is the polyp that you see. All right. So how best to describe this? You have your grapes, right? You get your green grapes, you have your Californian red grapes. You just peel the skin and it looks exactly like that. But you also have some blood vessel on top. Okay, these are pictures of my own of patients here. Okay, I just want to show you. This is a child, right? I want to show you. So you can see sinusitis with polyp over here. Okay, the polyp is not too bad yet. All right, there. This is the right side. Unfortunately, I can't get the other side going, but never mind. Okay, is there another polyp here? Huge one. Okay. Then you have all inside. Okay. Then sometimes you do have to do operation, and then what happens is that you have to clear up. You can see the sinus. These are all after surgery. Everything has healed up, and then you can see all open up. So sinuses are basically rooms. Okay, compartments. And you can see all open up. All right. Okay. So sleep and dentition disorder. A lot of times patients actually come in and say, or the parents will complain, my child has been breathing through the mouth. Very commonly, okay. So we have something called adenoid hypertrophy. Remember I showed you a picture of the scope as we go into the back of the nose. So it's called a nasopharynx. It's not a tumor. Don't worry. This is called an adenoid. So children, all children, okay, all newborns have adenoid. Adenoid is like the tonsil. So it's upper part of the nose. Yeah, it's basically lymphoid tissue. As the child grows, they will develop a good immune system, adequate immune system. So in initial part, the adenoid is basically like a filter. As we breathe in air, so it filter a lot of unnecessary and also immune response towards unnecessary pollutants. Okay, so they call adenoid. So the adenoid due to allergy can be very huge. This is not huge, I can tell you. We have adenoids that can actually go all the way and close the nasal cavity like a polyp. And then the child will usually open their mouth. This is a classical facies, adenoid facies. They have maxilla that is not developed, so it's like very sunken and flat, and then open mouth, and dentition can be a problem. If you look at, we call high arch palate. Okay, high arch palate, dental problem, malocclusion. The word is malocclusion, and then you may have to do expansion devices here. All right, you can see that. So these are problems, like I say, fairly common problem, or actually common problems. Child presenting with mouth breathing, so you have to look for allergic rhinitis, other forms of allergy, and then you look at the dentition, you look at adenoid hypertrophy. Yeah, and I want to add here something called asthma. So you may not be aware, you can go ask Dr. Google, you can just Google up ARIA, ARIA. You can see that there has been a worldwide dedicated program, and this has been going on for many years, since 2001, I believe, when they came out with the first ARIA guidelines. ARIA stands for, the acronym stands for Allergic Rhinitis and its impact on asthma. Okay, you can actually download this PDF file in the internet. So, okay, I should not go to treatment first. Yeah, I just want to tell you that in this ARIA guidelines, okay, it will tell you about the association between asthma and also allergy rhinitis. Okay, so you look for, every time you diagnose a child with allergy rhinitis, you also have to look out for signs and symptoms of asthma, and vice versa. So usually in a child with diagnosed with asthma, they will usually see the pediatrician first, and then the child will then should be investigated for allergy rhinitis, and also the severity of allergy rhinitis. So again, this is the ARIA guideline. So treatment, as you know, it has a trigger, so avoidance of allergen, and then you have multi-modality, take antihistamine. Okay, nasal steroid, the word steroids here I put in big words because I don't want to scare a lot of patients here who say 类固醇. Okay, so steroids, these are intranasal steroids, so they only stay inside the nose. So in lay person's term, I would call this the good steroids. They don't filter into the body, so they will not have any side effect. All right, and then nowadays we talk about immunotherapy and things like that. So in the guidelines, they'll tell you, okay, in a mild, different stages of severity of the disease will warrant different medication. So again, you want to highlight here, I cannot overemphasize the relationship between allergy rhinitis and also something called asthma. And I know there's something in between that the respiratory physician would allude you to. Is something called bronchial hyperreactivity. I want to also say here, they don't come with just wheezes. Sometimes just nocturnal persistent coughing can be the early signs of asthma. So do remember that. Alright, so where are we now in terms of allergy rhinitis? I just want to highlight here that we are now talking about immunotherapy. It's already available, dustmite immunotherapy. And also, this is going to be approved soon. we use cancer medication. Okay, shocking as it may be, all right. Dupilumab has been, I think they're close to FDA approval to be used for very chronic form of and persistent recalcitrant form of rhinosinusitis and polyp. Just to highlight here. Okay, so T, so E and T. So now let's go to the throat. I think T also stands for tonsillitis, very common. So again, side profile of the anatomy here. This is the nose, this is the mouth, and this is the throat. So of course, the throat we actually refer from the opening the mouth all the way down, okay, to the larynx here. Okay, so tonsils. Over here, both sides of the tonsils. Again, every child that is born will have tonsils, and the tonsils should digress. They should become smaller as child gets older. Except, of course, if the child has recurrent infection, the child has recurrent allergies, and then you have dental problems, and then tonsil. There's a period where they will regress. After that period, usually above 15, they will not regress anymore. So then they will tend to have problems. So you can see tonsils here. All right. So this is what I call a tonsil. Back out, right? I think my patients will tell me, okay, the term in Hokkien. All right. So I want to also caution here. A lot of times patients will come in. Again, the parents will come in and say, oh, I think I need to remove my daughter's or my son's tonsil because always infection. So I will tell you honestly that 50% of the time you don't need to remove the tonsil because it's not a tonsil problem. Because many of the times you can only have pharyngitis. This is a tonsil, okay? You have fairly good normal looking tonsil, but you have pharyngitis. So these are called, sometimes can be very inflamed. Pharyngitis starts from the word pharynx. That means other parts of the throat can also be inflamed. You can have this problem rather than just tonsillitis. Tonsillitis, usually you see all these white dots, and the exudates, we call it, on the tonsil. Because tonsil has crypts, has all these little lumen or depression where you can have food debris that gets stuck there, and then you can cause nidus of infection. That means a source of infection. Okay, so first thing that I do is that I would like to diagnose correctly, make a correct diagnosis whether it's just pharyngitis or tonsillitis. And also sometimes you have a fusion of pharyngeal tonsillitis. So if it's purely pharyngitis, you do not have to remove the tonsil because the child go through unnecessary operation and yet, okay, there's no end to the sore throat. So not all sore throat equals to tonsillitis. All right, if you can wake up and one thing to take away from this lecture is not all tonsillitis, not all sore throat is tonsillitis. Okay, very important. Okay, just to highlight here, there's how we do a tonsil. So this is will be the head end, will be the leg end. Okay, so it's a fairly easy operation. So you just nowadays I use something like what we call a radio frequency. Okay, I don't think you have time to show you here. So one side is around very fast. Okay, okay, done. All right, so this is how we remove the tonsil. Okay, so I want to tell you now about the anatomy of the neck. Okay, so you can see here the neck is not as simple. It's a very complex area of the body because it has so many different structures. You have what we call lymph nodes, and then you have thyroid, you have other things. Okay, so I want to tell you that in adults, we see a lot of patients in adult with neck swelling. This is where the neck swelling in adult differs from a child. So in a child, you do not see many what we call thyroid problem. Okay, usually it's an adult problem. Okay, but we have something called a thyroglossus cyst that can occur in a child. So it's something that is above the thyroid. I'm going to show you in a short while. Another common neck problem is what we call lymph nodes. You heard of lympha, okay? All these lymph nodes. So we have many lymph nodes in the body. So usually due to infection, but of course, if you have something that is persistent, lymph node swelling, lymph nodes that is not painful and it persists, you must always look out and be a bit more suspicious. So different sort of neck swelling that we see, okay, such as the brachial cyst, lipoma, thyroglossus cyst. This is the thyroglossus cyst. It sits above the thyroid. Okay, so here you can see a thyroglossus cyst, and the operation is something very interesting. It's called a six-trunk operation. You don't just remove this, like in thyroid problems. When we remove, we just remove the thyroid. But for thyroglossus, we have to remove part of the normal part of the body, which we call the hyoid bone. Part of the bone of the hyoid has to also be removed. If you don't do that, then you stand a high risk of recurrence. So something called a six-trunk operation. So these are common neck swelling that we see in a child. I want to also tell you, we see children with noisy breathing. And in a bad scenario, remember I told you we don't have many emergencies, but epistaxis, bleeding, very bad bleeding from the nose is an emergency. Noisy breathing is also an emergency because you cannot breathe well. You have obstruction in breathing, patient die. Okay, so these are fairly common pediatric problem that has to do with noisy breathing or stridor, something called laryngomalacia, and sometimes you have foreign body that is fairly common, relatively common. I just want to tell you about foreign body again. It can be quite insidious, as in if you don't suspect a child having foreign body, they don't present, child obviously will not be able to open their mouth and say, oh, mommy, daddy, I have a foreign body stuck in my airway. Obviously, you can't do that. So their presentation can be quite different. It can be only cough problem, lung infection in a very healthy child. Okay, so sometimes this one, the pediatrician will have a very high index of suspicion. They will be able to do some chest x-ray. Sometimes they have to do CT scan, and then they think, oh, it could be a foreign body. So we have to then get us involved, and then we do something called a bronchoscopy, and try to look out for this foreign body to remove. And then it usually happens when a child starts mouthing. Okay, when they start putting out, they can put into your mouth. So be careful of this foreign body in the airway. And then laryngomalacia, fairly common. Fortunately, it is a benign problem. A child usually will grow through this period, and then they will get better. Like I mentioned earlier, that a lot of the structures in the ENT part and also the lung is still growing as the child is born. So the cartilages inside the throat, inside the larynx, is still growing, or is still not as strong as what it should be. So you have this something called a malacia, all right, laryngomalacia. All right, so this is what happens. I just want to show you here. This is the normal vocal cords, okay, and then this is the abnormal vocal cords, and also part of the larynx in a child with laryngomalacia. Okay, I think, do I have I don't have a picture. I thought I have a picture of how the larynx looks like. Oh, I don't have it here, I'm sorry. No. Okay. All right, so I think, yes, that's more or less I've covered ENT. Of course, I've not exhausted the entire list. I've just skimmed the surface. So, I think there are some questions and answers segment here. All right, what do we have here? Oh yes, Malati. Hi Malati. Do you have any treatment for septal deviation? Yes, of course, definitely. We call usually we do something called a septoplasty. All right, so but again, we try not to do it in a child again. The standard practice is to do after the child has attained 18 years of age. But the next question, have I done? Yes, of course I've done for children, very bad ones. They can't breathe at all. And what happens is that when you have a deviated nasal septum, if it's not problematic, that means you look in and then you find, oh, on and off I may have a bit of blockage, and that's about it. In a child, I tend to tell them to wait it out unless they develop complications. So what are these complications? So one of it is, of course, they develop very bad sinusitis. All right, so my last child was a year and a half ago. Okay, she's about 8 years old. I had to go in to correct the septum because she has been having recurrent sinusitis, which also needs surgery. So it was very bad. So once the deviation is corrected, then actually I've not seen her. I've seen her so many times before. I think, yeah, that reminds me, I've not seen her for the last 1 year. Okay, so so septoplasty is the treatment of choice for deviated nasal septum. All right, and I think the other question earlier that I promised to answer. Oh, yeah, so epistaxis, yes. So a parent experiencing the first episode of epistaxis in a child can be quite traumatic. I understand that can be quite emotionally traumatic. So I think sometimes us doctors, we tend to put aside and say, oh, it's just a small little thing, because you've seen so many times. But again, I can tell you, it can lead to a lot of other problems if you don't handle it properly and professionally. So child 7 years old is very common for them to have sudden epistaxis at any time of day, middle of night, in the middle of the heat of the day. All right, and then sometimes you say, oh, the child may not, I don't see any scratching of the nose, nasal picking, but sometimes it happens involuntarily in the middle of the night. And then air conditioning cause crusting, dryness of the nose, and then it can also lead to epistaxis. So when I see a child, I will of course teach them those minor cases. The parents will learn how to apply some medication, how to stop the bleeding in the correct manner, and you allay their fears and you follow them up. Rarely that we have to do any surgery to correct this problem. Very rare. Okay, so this is what I can say about epistaxis. Do I any questions? You want me to go through some questions here that you okay? Oh, okay. So I think this is from the fellows here. My child wakes up with a runny nose or sneezing fit every morning. Is this normal, or should I see? Of course, it's not normal. Then again, I think I did mention something called the ARIA guidelines, and I also told you that different form of allergy has also different severity. You can have mild form, you have moderate form, you have severe form. Of course, I usually do not see. I'm not a GP, so a lot of times parents that come and see me, they will have seen the GP, and then they will have started some medication, and only if it does not get better, then they will see us. So you don't have to jump straight to see us. Sometimes they also see the pediatrician. So will kids with sensitive nose wake up with more nose block or sneezing than normal? Yeah, definitely. So like I say, the itchy A, B, C, D, E. Okay, can you remember that? Itchy A, B, C, D, E. I tried cleaning the room, I vacuum. Yes, unfortunately, like I said, okay, the environment can be innocuous, can be clean, but our body, some of us, we have a so-called a higher exaggerated immune response. That's the whole idea about allergy. We have a exaggerated immune response that react to so-called harmless, innocuous stimuli. So you can be doing that. Unfortunately, you may still need some medication. You may still need to fine tune a bit to get rid of this problem. Okay. Another question here from Jay. Hi. What is your suggestion for treatment for someone with chronic sinusitis? Oh, okay. So, of course, obviously, I cannot answer in this. Cannot satisfy that question appropriately with just this one session. Chronic sinusitis again is a topic by itself. Actually, not just a topic by itself. Okay, I can tell you we have conferences, a 3 day, two nights, 4 days, 3 nights conferences on chronic rhinosinusitis. Can you imagine? Huh? And then we have different European EPOS body, we have a AO American body, has all dedicated to different forms of allergic rhinitis, different forms of chronic rhinosinusitis. Okay, so in a nutshell, okay, I tried at best to answer your question. Treatment, of course, you have treatment. We see chronic rhinosinusitis is very common in the adult population. Like I said, we are seeing more in pediatric age group. Unfortunately, you need a long follow-up. Some patients may need more frequent follow-up, some may not. But chronic rhinosinusitis, I'm not too sure how bad is your definition of chronic rhinosinusitis. We have a different severity. We have also different forms of rhinosinusitis. But safe to say, I would say 95% of the time we manage our patients very well. Okay, we are with patients with chronic rhinosinusitis. Unfortunately, you have that 5% that may have to come back quite often to see us, may have to go for some sort of surgical procedures to help them out. So I believe in a lot of douching, nasal rinse. Have you heard of something called the Neilmare, the flow sinus? It can also be used in children. I will teach the children myself in my clinic to do, and they're quite happy to do, and no problem whatsoever. Nasal rinse is very, very important in the treatment of rhinosinusitis. And also, I told you the many modality of treatment. Okay? All right, any other question from here? Okay. Hi, Nadia. Your question is on, yeah, tympanic membrane, yes. Okay. So I assume you are an adult. I'm not too sure when you had your tympanic membrane ruptured, but if you had it for a long term, that means anything more than a year, it will usually not recover. Okay, the perforation will not recover. However, do all patients with ruptured eardrum go for surgery? The answer is absolutely no. Okay, again, I always follow the books. I believe in doing the right thing, follow protocols. So sometimes you have pinhole perforation, small little perforation that do not cause any problems, no hearing deficit or very minimal problems, no discharge. Okay, you don't swim. Of course, a patient with an eardrum perforation should not swim. Okay, then you do not require any surgery, but you definitely do require follow-up. Okay. Okay, I have another question from Connie. Do you think the purifier? Yes, yes. I always also believe as doctors we should do no harm. So I think the purifiers do no harm. So then usually we'll have a long discussion on what type of purifiers in the clinic. So I also learn from my patients. Okay, some of them are a lot smarter than me, so they use different expensive type of purifier. But I believe in principle, yes, purifiers do work. Okay, purifiers do work. All right. Okay, let me go. I think. Oh, how many questions are here? Okay, four. Okay, let's just finish these two questions and we are done for the day. My child wakes up with a sore throat every night. Oh, okay, and then goes away. So, like I said, this is quite classical of patients who come to see us. This is not an infective sore throat. That means it's not the infective origin. It's not because you have infection then you get sore throat. So it could be a child with a mouth breathing child, opening their mouth when they sleep, dry air goes in and then cause a lot of dryness and then waking up in the morning with sore throat. And then as of course as we awake, we tend to eat, we tend to have more saliva going in and lubricating the mouth, so the sore throat will go away. My child develops a runny nose several times in a month, but none of this lasts longer than a few days or weeks. Is there any? Oh, okay. So again, intermittent time of the year, or especially in the temperate countries, we also see here. We don't have proper 4 seasons here, but I can tell you a lot of patients will have different uh, parts of the year they develop some exacerbation of allergy. So look out, you have to be in a PI, a private investigator yourself, and look out for triggers. Uh, uh, that could, like I said, things that you inhale, things that you are in contact with, things that you ingest, all right, and things that are injected. Any form of stimuli that can develop allergy reaction. Okay, so I'll leave you with this my most favorite illustration, my most favorite cartoon for a very obvious reason. Okay, so ENT doctor, if I'm in the animal world, probably these will be my 3 most popular customers, right? The giraffe, the elephant, and also the rabbit. Okay, so I think I'm done for the day. All right, it's been 4 o'clock now. So thank you very much. Thank you very much. Okay, have a good day. Bye. And stay safe.